And this means that when services are trying to think about what they should be doing to support people with learning disabilities from ethnic minorities, they don't have clear instructions from the government about how to help and support people. Can I have the next slide, please, Christina? So in terms of a little bit more detail about what we did, as I mentioned, we reviewed 36 national policy documents for England, 1 or 2 from other places. From 2001 onwards, we picked 2001 because it was the year that Valuing People, the white paper Valuing People, was published. So that seemed a good starting point. Policies, we included a number of things under the umbrella term of policies because lots of different kinds of things are written that have an influence. So first of all, we looked at NHS England and other national policies relevant to people with a learning disability. Secondly, the Department of Health and Social Care also regularly produce responses to major reports. And in those responses, they often include instruments of policy and guidance as to what should be done. And we also looked at relevant white papers, for example, the Care Act or the recent Social Care White Paper. Policies rarely mention inequalities in the lives of people with a learning disability from ethnic minorities. So the notion of health inequalities that people with learning disabilities as a whole population experience, that's become more common. But when it particularly comes to the inequalities that people from ethnic minorities experience, those are very rarely mentioned. Recently, leader reports, which I know we'll be talking about in a bit, they've been highlighting real differences, inequalities across ethnic groups in terms of people with learning disabilities and age of death. And the government has, in their responses to those reports, have been recognising that those inequalities are there and they are serious. But despite this, as yet, specific policy directions relating to people with a learning disability from ethnic minorities are pretty rare. Have the next slide, please, Christina. So from the policy review, we came up with 2 general recommendations. The first is for the Department of Health and Social Care, which is basically very straightforward. When they are developing future policies relating to people with learning disabilities, they should include advice that has used co-production approaches to tackle the health inequalities of people with a learning disability from ethnic minorities. So policies about people with learning disabilities should also include guidance related to people with a learning disability from ethnic minorities. So that's future policies. There is also, of course, a lot of current policy relating to people with learning disabilities where there isn't explicit guidance relating to people from ethnic minorities. So our second recommendation is for NHS England, and that's to take the policies that already exist and to do some co-produced work to produce additional guidance from those policies relating to people with learning disabilities from ethnic minorities about tackling the health inequalities that people experience. So that was the policy review. The second thing we did that was led from Manchester Metropolitan University was a review of administrative data sets. If I could have the boxes, please, Christina. So basically, administrative data sets is a big, long jargon term. What we mean are simply big files of information about people that are collected by organisations like the NHS and local councils. So, for example, when we're looking at GP records, they collect information about learning disability, they collect information about ethnicity. If you put those together, you get a big set of information. And those big sets of information can be really useful about knowing how many people with a learning disability from different ethnic communities there are, for example, in England, or what kinds of services are people using or not using. So they can be really useful to provide some sort of background information that really helps policy and practice. Altogether, we looked at 27 different data sets to see what information they have about learning disability and ethnicity. And these data sets were, for example, about benefits or about people with children with special educational needs attending school, or people using social care, or people using health services. And basically what we wanted to know is, did they say anything about learning disability, and what did they say? And did they say anything about ethnicity, and what did they say? We found overall, I mean, all these different data sets have very different histories and they have different purposes. And that means that they have very different ways of describing ethnicity in terms of kind of how people are put into different sort of boxes or categories around which ethnic community people are in. And they also have different ways of describing learning disability. So sometimes that's quite specifically learning disabilities. Quite often it's a very broad category that also includes people with specific learning difficulties like dyslexia. So when you put all those things together, it can be quite hard to understand what they mean, and particularly whether you can pull different ones together to come to some kind of really important and useful conclusions. So at the moment, these data sets on the whole are not being used to keep an eye on the health and experiences of people with a learning disability from minority ethnic communities. So if we have the contents of this slide, Christina, that basically kind of restates in a bit more detail what I've said. We looked at 27 data sets in England. We found they're very different in what they capture and also how well they capture it. Sometimes it's reliable, sometimes it's not. Only 5 out of the 27 data sets contained publicly available information that compared some aspect of the experience of people with a learning disability across ethnic groups. 1 related to children in schools, 2 coming out of surveys with adults and with family carers, and 2 around people with learning disabilities in inpatient units. So there's a lot of potential there, but they're not being used at the moment. So again, we have a couple of recommendations. For NHS England, there's a fantastic resource that they produce every year called the NHS Health and Care of People with Learning Disabilities dataset, based on over half of GP records in the whole of England, compares people with learning disability to other people on all sorts of aspects of their health, on aspects of use of health services. It would be great if ethnicity could be added to that data set so people can use that to explore similarities and differences across ethnic communities of people with a learning disability in terms of health and healthcare. And we need to have a look if we can make that more consistent. So how learning disability is characterized and how ethnicity is characterized, so we can make more sense of what's happening across different data sets. For ICSs and ICBs, integrated care systems and integrated care boards, when you're collecting data, do make sure that you're routinely and accurately collecting ethnicity data relating to people with a learning disability. The better that data is and the more complete it is, the more we can use it to understand the experiences of people across ethnic communities. Thank you. I'll pass you back to Umesh.
It's me actually, Chris. So I'm Christina, I'm a researcher at UCLan, and I'm going to talk through the scoping review that we conducted. So scientists write articles to tell people about the work that we do, and we call this research. And we looked at what we already know from the research about people with a learning disability from ethnic minorities. And we found that there's not enough research about people with a learning disability from ethnic minorities. And lots of the research we did looked at South Asian people, and there's not enough that looks at other ethnic minorities. Big groups like Asian or South Asian are often used in research, and this can be really useful to look at how racism affects people's experiences or outcomes. But it's important that researchers try to look at smaller groups to see if their experiences are the same. So now I'm going to go through in a little bit more detail. So we conducted a literature search on electronic databases, and we focused on the access, experience and outcomes of healthcare for people with a learning disability from ethnic minorities. So we screened the papers and around 7,000 records were found. And then after screening them to make sure that they included information about people with a learning disability from ethnic minorities, and that they focused on access, experience or outcomes. We included 94 papers in the final review. 36 of these papers were mixed methods or qualitative studies, and the rest were quantitative. So we developed some themes, and what we did is we took the preliminary findings from the scoping review and discussed them with our working group. And they told us what they thought of the findings so far and things that they thought were important that weren't being captured at the moment. So they were developed through an iterative process between the academics and the working group. So what did we find? We found that most studies focused on outcomes in some way. 34%, and these were mostly qualitative, looked at experience, and 21% looked at outcomes. We replicated findings from a previous scoping review, which found that we don't know very much about the health status of people from ethnic minorities with a learning disability. So the majority of these studies looked at mental health outcomes, such as rates of detainment, mental illness, or psychiatric symptoms. And there were 6 studies about COVID-19. And very little about other health outcomes. We found that the most represented group were Asian or Asian British, making up 31% of the sample in these studies. And white people were well represented, but these were often used as a comparison group. We found that groups such as Gypsy, Roma and Irish traveller communities, asylum seekers and East Asian communities were hardly represented at all in the literature. So in terms of our themes, we found that only 2 studies focused on discrimination, and often studies did not discuss barriers to healthcare through the lens of discrimination or racism. The literature suggested that South Asian groups had more family members in their social network, and these were often their support. And high levels of stress were found in carers of people from ethnic minorities with a learning disability. Leader tells us that people may die at a younger age, and that males from an Asian or Asian British background with profound and multiple learning disability had a median age of death at around 30. In comparison, for the white group of males with profound and multiple learning disability, the median age of death is 59. In terms of COVID-19, we found that although ethnicity and learning disability were risk factors of adverse health outcomes and death from COVID-19, they weren't analysed in terms of an interaction between these 2 factors. We found greater levels of unmet need in relation to culturally appropriate services in South Asian communities compared to those of Caucasian groups. And we found very little about the Learning Disability Register, but several papers did use the register as part of their recruitment or analysis. So what do we want to happen? Well, we want integrated care systems and boards to develop interventions for carers of people with a learning disability to promote their well-being. And we want specific research to be commissioned in underrepresented groups. And we want researchers to look at how people with a learning disability understand and conceptualise racism. I'll now hand over to Umesh, who's going to go through the next part of our report.
Thank you, Christina. If I could have all the boxes for the summary slide. This was a practical example of what can be done. So as I work for Lancashire and South Cumbria ICB, it was possible for me to do this. So in brief, doctors record, as Chris has mentioned, in terms of record ethnicity as part of their quality outcome framework and database for recording learning disability on their registers. And that helps us to inform us about what we need to do and help specific patients. And ethnicity is an important element of that, because there are certain conditions that you're more likely to be affected in certain groups. And so we looked at what GPs are recording in their clinical systems, and we were able to look at how there might be differences in how that's being recorded. And so this is the information that we were able to look at. And it's not always right, is what we found. So next slide, please, Christina. So this is a study over Lancashire and South Cumbria ICB, which has roughly 1.5 million people across what used to be 7 CCGs. And in there, at the moment, we have something like 8,000 patients who are recorded as having learning disability, and the prevalence varies across the different areas in terms of how well this is recorded. Ethnicity is supposed to be self-identified. It's quite a complex construct to understand sometimes, and we're not quite sure how well that is communicated across to people with lived experience. Next slide, please. And what we found was that on the face of it, if you looked at just the crude data, about over 92% of people had some sort of ethnicity recorded. But when you broke that down, only just over 70%, so a quarter, don't have the right valid code. Next slide bit. So, and as I said, the prevalence we found was around 0.5%, but in some areas it's less, it's about 4.8%, and in other areas it's up as high as 0.6% in terms of how well somebody's recorded as having learning disability on their records. Next slide. The variation we found in terms of coding of ethnicity, that there are poor coding kind of practice, and one of those is just to say somebody's white British, or just British, or is English, for example, or bright British Asian. So there's not necessarily following a set standard. We've tended to have data going back to 2001 when practice were encouraged to use census recording, but we've had 2010 and 2021 when we've had census kind of recording process, but those aren't necessarily being followed in primary care. Next slide, please. So what we've highlighted is there's a significant variation in terms of how ethnicity is coded across even just Lancashire and South Cumbria, with over a quarter of the people having their ethnicity recorded inappropriately, and that at the moment there's no mandated process for recording ethnicity across the NHS. Next slide, please. So in terms of recommendations, we think we need to develop a procedure or guidance for doctors to have self-disclosed ethnicity information provided to patients, and update the NHS directory so it meets up with the census data, the latest census data. And theoretically, there's no reason why we couldn't do this across the whole of England in terms of validating how well ethnicity is recorded, and potentially look at quality improvement projects that could help try and improve that. Back to you, Christina.
Thanks, Umesh. So I'm going to whiz through the LEADER findings because we don't have much time. So LEADER looks at the lives and deaths of people with a learning disability and autistic people in England. And when someone dies, they can have their death reported to LEADER. A review was then assigned who looked at what happens to them, and they write a review. So we looked at people who died between 2018 and 2021. And we found that ethnic minorities died younger than people denoted as white. And for every 10 deaths reported to LEADER, 9 were of people denoted as white. So we don't think enough people know about LEADER, and that we don't have enough information about people from ethnic minorities who die. So now for a little bit more detail. So again, the LEADER programme reviews the deaths of people with a learning disability and autistic people as of June 21 over the age of 4. And we use data from notifications to the programme and completed reviews of the deaths from between 2018 and 2021. So in terms of the notifications of deaths, as you can see from this chart, 90.2% of people that are notified to LEADER are denoted as white, and 9.1% are of an ethnic minority background. We looked at the median age at death of people from different ethnic groups. And we looked at over 11,000 people in the white group and around 1,000 people in the ethnic minority group. And as you can see, that the median age at death for all ethnic minority groups is significantly lower than the white group. And the median age at death overall, when we pull together all the ethnic minorities, is 34 compared to 62 for people denoted as white. But we have to say that the people in the ethnic minority group is considerably smaller. It's around 10% of those in the white group. We looked at the leading causes of death by ethnicity. And we can see that in 2018 and 2019, there were differences in the leading cause of death. But in 2020 and 2021, those differences level out, and COVID-19 becomes by far the leading cause of death for all ethnic groups. We tried to model the effect of ethnicity at age of death, and we did something called a Cox proportional hazard model to investigate how ethnicity could predict age at death. So we modeled data relating to around 11,000 deaths of adults that had ethnicity data available between 2018 and 2021. And we fitted a model with ethnicity as the predictor variable to estimate the effect it has on age at death. And in this model, the white ethnicity was used as the reference group. And as you can see from this chart, that all ethnic minorities had a higher hazard ratio than the white reference group. So that indicates that being of an ethnic minority puts you at a greater risk of earlier death than being denoted as white. So what do we want to happen? We want NHS England to undertake a targeted awareness campaign for ethnic minority communities to tackle the underreporting of deaths so we can have more data about ethnic minorities with a learning disability. We want researchers to conduct research at what's driving a lower median age at death in ethnic minorities with a learning disability. Thank you very much. Back to Habib.
Great, thank you. Thank you so much, Umesh, Christina, and Chris, for that powerfully insightful overview of the data and policy. I mean, the ethnic disparities in life expectancy alone, 34 years compared to 62 years. I know small numbers, but that's stark and that's shocking. Thank you so much for that. Please remember to place your questions in the Q&A function for the panel session a little later on. At this stage, I guess it's important to highlight, alongside the quantitative data and review, the qualitative richness and insight of lived experience, which has been at the heart of this review. But before we go into the detailed findings of that element, we have a presentation from Siraj Nadat and Aisha Edwards. Siraj is a senior quality of life facilitator at rights-based organisation Changing Our Lives, and Aisha Edwards is a People Parliament representative for Lewisham Speaking Up. If I can hand over to you two for your presentation. Thank you. Siraj, I think you're on mute.
Yeah, sorry about that. Yeah, my name is Siraj Nadat, and I was part of the working group. For me, I think all the speakers have raised very poignant points that are included in the report itself. For me, I think it speaks a lot about racism and intersectionality. Like like you heard the video and the speakers talk about, and I think racism is at the heart of it, because as you can see and heard that people with learning disabilities from an ethnic minority group are getting the real deal, and they are, we need to address this at every level. And intersectionality comes hand in hand as well, because the people are facing double discrimination. First, this about the disability, and then about the ethnicity as well. And one more point is that since COVID happened, that Christina put it out, that every group is under the COVID COVID and as we can see, a lot of causes of death are because of COVID. So we need to work all together to combat this as well. Back to Habib.
Thank you so much, Siraj. I'm not sure whether Aisha is online.
Yes, Aisha's with us.
I'm not sure whether she's able to connect and speak, Jabir. Maybe we move on to the next item and we could bring Aisha in when she is able to. I'll check in with my with the organisers at the same time, if that's okay.
She is online. She may just be not able to unmute at the moment. So
okay,
let's move on then.
Sure. Brilliant. Well, thank you so much, Siraj, for your presentation, and we'll hopefully hear from Aisha a little later on. But thank you for your invaluable work also on the review, which has been critical for us in order to kind of make sure that we have lived experience, of course, at the heart of all that we do. Now is the time for part B, the qualitative findings and more detailed information around the qualitative aspects of this review. So I will hand over to Jabir Butt, who's the Chief Executive of the Race Equality Foundation, and Katie Umpleby, who is a Research Assistant at the University of Central Lancashire. So over to Jabir and Katie.
Thank you for that, Habib, and thank you for Siraj and Aisha. You'll have seen that they appeared in the video already, and they were a key part of the working group that participated in the development of this work, and importantly played a part in the qualitative work as well. We're going to split this presentation into two halves. Firstly, Katie is going to talk us through some of the findings from the qualitative work. And then it's going to return to me to talk about some of the implications. These two pieces, the quantitative work and the review of literature, was linked to the qualitative work by us firstly identifying some of the themes in the research literature, and then using them as part of our discussions in the qualitative work. So I'm going to hand over to Katie now to talk in more depth about that. Over to you, Katie.
Hello, good afternoon, everybody. As Habib introduced and said, my name is Katie Umpleby and I am a member of the research team from the University of Central Lancashire. So this section of the report is about what people told us about their experiences of health and care services. I will now briefly summarise what we found. So we ran workshops where we spoke to self-advocates, carers and support workers. Please will you click next, Jabir, thank you. So lots of self-advocates told us that they were not treated fairly because they have a learning disability. Please will you click next twice, thank you. However, people found it hard to understand if they experienced racism. Racism is when you are treated unfairly because of your ethnicity. Please can we go to the next slide? So some carers said that because they are Asian, sometimes healthcare staff guess that they have a big family who help them, even though this is not true and they do not have help from family. People told us that there are not enough staff from their culture and this makes them miss out on being in their community. And carers said sometimes that people in their community do not understand what a learning disability is. This makes them feel lonely. I'm now going to go into some more detail about these workshops. So we conducted experience-based co-design workshops, and in total 20 people took part. There were 13 self-advocates, 5 family carers and 2 support workers. These participants were recruited with help from Learning Disability England and the Race Equality Foundation. There were 3 workshops, and these were held in Lewisham, Leeds and online. People who could not attend the workshops provided their thoughts directly with the research team. So there were 8 core themes, and these were generated from the findings of the scoping review and through further discussion with the working group. These themes were translated into an easy read format and were shared with participants prior to their attendance at the workshop. Each workshop enabled people to talk about the themes that were most pertinent to their experiences, and discussions of these themes were facilitated by representatives from Learning Disability England and the Race Equality Foundations. Finally, the conversations from these workshops were transcribed and thematically analysed. I'm now going to give you an overview of our findings from these main themes. So people told us that the COVID-19 pandemic caused more difficulties with access, and self-advocates said that they experienced loneliness and uncertainty caused by their reduced access to support networks. So the next theme relates to transition. We collated 2 transition themes relating to transition between services and the transition from child to adult settings. Carers told us that there was a lack of support and information during periods of transition, which resulted in a fear of their children transitioning to adult services. And people also told us that there was a lack of communication between healthcare services. Our next theme, please, refers to the Learning Disability Register. So whilst people recognised that they received annual health checks, there was a lack of awareness of the Learning Disability Register. And self-advocates identified fear as a potential barrier of wanting to be recorded on the Learning Disability Register. So if you can have the next slide, please, Jabir. So our next theme refers to discrimination. So some participants experienced discrimination. However, people found it difficult to understand whether this was due to their disability or due to their ethnicity. People reported instances of reasonable adjustments not being adhered to, such as a lack of easy read information and inadequate appointment durations. However, some people told us that they may have been treated differently due to their ethnic background. This included being spoken to in a distasteful way and being prompted to pay for services which were expected to be free. So I'm now going to move on to the community and family networks theme. So support from these networks were really important for the general health and well-being of self-advocates. And self-advocacy groups were important too. However, sometimes culturally appropriate services were unavailable. When we spoke to carers, they expressed that they lacked support from their wider family and within their communities. And this was possibly due to the stigma of learning disability. And this resulted in feelings of isolation amongst carers. And finally, carers felt like healthcare professionals held the stereotype that South Asian families have big support networks, despite in the carers' experiences this not being the case. So on to LEADER. So discussions of LEADER were really limited to highlighting a lack of knowledge of the programme. Not many people had heard of it, and therefore people reported that targeted information about LEADER is really important to raise awareness of the programme. So the final theme on the next slide, please, Jabir, relates to digital access. So self-advocates told us that they sometimes still require support to engage with digital technology. And people also told us that there was a lack of easy read healthcare information online. I'm now going to pass on to Jabir, who will talk us through the implications and the recommendations that have derived from these workshop findings. Thank you very much.
Thank you, Katie. And I think the starting point has to be where Siraj left us, which was that intersection between disability and ethnicity and the experience of racism that perhaps compounded discrimination.
There are clearly challenges around this discussion with Black, Asian and minority ethnic people with learning disability, but there's clearly evidence already that's been shared today that suggests that there is something going on there that requires particular attention. It seems to suggest that discrimination exacerbates inequalities in access and experiences of healthcare for people with a learning disability from these backgrounds. We've heard mentioned several times the importance of communication, but also the persistence in stereotypes is a real challenge. There are, when you get to read the report, you'll see there are gaps in our evidence, particularly for Black communities and people from a Black background with a learning disability. But nevertheless, that experience of discrimination seems to resonate across minority communities. However, recognizing and understanding the source of discrimination can be difficult for people, and is a conversation that perhaps we need to get better at and to encourage people to be involved in as well. Although ultimately it doesn't matter what the source of that discrimination is, what we need to ensure is that people are able to access the support that's needed in a timely and appropriate fashion. Understanding and the starting point for that has to be understanding an individual's needs from the first point of contact for the allocation of resources. We've got to get better at seeing the person in the room with us, seeing the person is in front of us, and trying to best understand their needs and best understand how we can provide that support most effectively. We've already raised a set of actions that and it's important to emphasize those again. In terms of the NHS England, all organisations providing health and care must meet their statutory requirements for providing reasonable adjustments in line with the Equality Act. That discussion about attending annual health checks repeatedly raised the worry that often people with a learning disability from Black, Asian and minority ethnic communities weren't getting communication in an easy read format, making it more challenging to actually understand what was being asked of them and to attend an annual health check. What we've seen elsewhere as being a key part of the preventative work that can be done. We certainly need to have awareness campaigns that are needed to explain the value of being on the learning disability register and attending those health checks. These things, I think, go hand in hand. It's not either or. Both those need to happen. With the new structures that are being put in place for the way health and care is organised, there are some recommendations for ICBs and ICSs as well. Culturally appropriate community-based support and self-advocacy groups should be commissioned. It's clear that advocacy and self-advocacy makes a real difference, but for it to happen, we need to commission those organisations to do it and to do it well. And hopefully, the boards will take that on board as part of the work that they now do in the coming years as a result of this report. Over to you, Habib.
Great, thank you. Thank you so much, Jabir and Katie. That's absolutely fantastic. And we are now at the point, right on time, for our question and answer panel. So we have a panel which is representing different perspectives and angles. We've got Umesh, Jabir, Christina, Siraj and Aisha joining us from earlier presentations. And I also have the pleasure of introducing someone that I've learned a lot from in the past and look up to, the wonderful Tom Cahill. Tom, if I quickly introduce Tom, who began his career as a mental health nurse and held several senior posts before joining Hertfordshire Partnership Foundation Trust as Chief Executive. And under Tom's leadership, the Trust was rated as outstanding by the Care Quality Commission in 2019. Tom joined NHS England in 2021 and is working alongside the National Mental Health Director, Claire Murdoch, to lead work on driving up standards of care across the health service for people with a learning disability and or autistic people. So welcome, welcome, Tom. If I can, obviously, please do put your questions in the Q&A function at the top, and we will ask as many as we can over the next 25 minutes. But if I can kick off the panel session, and if it's okay, Tom, I'll go to yourself first for your key initial reflections on the review, and to also ask, I guess the fact that we have the data and now we have the insight from the data, in your view, what needs to be done to turn this insight into action?
Thank you, Habib, and thank you for your introduction. Welcome, good afternoon, everyone. A fairly simple question that has a really complex set of answers. But first, let's say thanks to the Race and Health Observatory for conducting the review, University of Lancashire and other colleagues. But most of all, thanks to those with lived experience who took the time to tell us their stories. They're pretty profound. We can talk data, we can talk all of that, we can talk services, but when you read people's experiences, they're pretty profound. On one hand, the report offers us another opportunity to understand what experience of learning disability people with a learning disability is when accessing care, but in particular those from an ethnic background with a learning disability. It reminds us that, you know, in 2023, we're still hearing of people dying young at ages 13, 34. We're hearing of people's experiences and can't get access to services and often frightened to do that. And you know, we have to think. I'm a mental health professional. I've been in the NHS all my career, and to think that this still is there is particularly difficult. That said, it gives us an opportunity now to double down and think about where we go next. And I'll just say a little bit briefly and what I think, without it being a sort of full answer from NHSE, but we clearly need to do more around the data. And we're working with GPs in the contract about how do we pick up data, but we need to be broader than that. We've got the digital flag that we're looking to roll out, and I think personally that's a game changer if people know what to do once they understand. I think we have issues around access to suitable services and those that are culturally ready services. We need to continue to look at experience. But we have to ask ourselves, why is this so difficult in 2023? And there's got to be a hearts and minds conversation. There's got to be an understanding so we can do the data. What happens if you know there's somebody coming into your trust or into your care who's got a learning disability and comes from an ethnic background? Do you know what to do? Do we understand what to do? So we have a real continuation of, I think, of a hearts and minds and a culturally aware. And that's not just with primary care. That's with hospitals. That's with social care. I'm struck by the work that we've got to do around our policies. A real reminder at the beginning about, do our policies enough reflect ethnicity? I'm clearly minded now they don't. But again, so what if we put it in a policy? What is the change? And I think finally I'll say in the opening is, Jabir talked about a new system in the NHS, which is around ICBs and ICSs. We have a real opportunity to localise this debate. We have an opportunity for local leaders to work with us at a national level, but to work with their local communities about who's in your community, what are the services you provide, and what are the ones and how can you adapt those to meet the needs of your local community. So there is a role for national, but there's also a role for us to try and really do something locally. Habib, I'll stop there and I'll happily take any further questions.
Great, thank you so much for your initial views and those pertinent points, Tom. Just a second question that we've got coming through, actually, just building on that local aspect. I'll post this question to Jabir and Katie in terms of the qualitative aspects of the review. How will people and communities at a local level feel actual positive change?
An easy question then, Habib. I have to say that that's going to be the ultimate test of how successful this report has been. I think there are key challenges that people can address now that don't necessarily require additional resources, but it requires us to do our work better. the starting point is about making sure that everybody who should be on the learning disability register from Black, Asian and minority ethnic communities is on there. We've seen some incredibly good work taking place in places like Nottingham and the Wirral, where specific effort is being made to ensure that people with learning disabilities are not only attending their annual health checks, but their ethnicity is being better recorded. Lewisham Speak Up is doing a similar project as well. It's all within existing resources, and I think if we can do that better, it's a starting point. The next part of it is that other point that we've made and several people have made, and builds on Siraj's earlier point as well, is that we actually need to create practice that sees the person in front of them rather than some stereotype. And I think that that's something, again, as good practitioners, we should be able to do. We should start thinking about challenging those stereotypes and hopefully working better. The final thing I think is trying to engage with our local communities better, and the ICSs and ICBs it's part and parcel of what they're meant to do in terms of how they work in the future, is to build on better engagement. Katie, I don't know whether you want to add.
No, I think you answered that perfectly. Thank you, Javier.
Great, thank you so much, Javier. And there's also something about sharing replicable good practice widely as well, and there's certainly a role for the centre and for ICSs, I believe, going forward in that respect as well. We have a question which I'll pose to Siraj, and Siraj may have some views on this. It's around easy read documents, that the question says that they are always produced in English. Is there any scope, or would it benefit having easy read versions which include some text in different languages as well?
I mean, yeah, I mean, that's in the system, really. I mean, I've never seen easy read information in the languages. They do have text, but they don't have the standard format, and I think that would be a lot better. And if the health services or any services could produce that, I think that would make a big difference as well.
Great, thank you, Siraj. Absolutely agree. Inclusivity is cultural sensitive information is absolutely critical for us as well. There's a specific question around data and ethnicity which I'll pose, which has come through. I'll pose to Umesh, Christina, and Chris for one or more of you to answer, and that's around, of course, the importance of ethnicity monitoring, but there seems to be an over focus on 2001 census categories for ethnicity. The question is, when can we move over, or what would be the benefit, I guess, in the immediate term, but also the longer term of moving over to 2021 categories, and how quickly can that happen? So that may be a part question for Umesh, Christina, and Chris, but also perhaps for NHS England, Tom, as well. I'll go over to Umesh, Chris, and Christina for their views first.
Thanks, Habib. I think the important element for me has been that through this research, what we've possibly done is scratch the surface in terms of inequality. I'm not necessarily surprised by the findings, but being able to display the differences has been really important. The fact that there are different ways of recording ethnicity and it's not standardized does make it difficult to make sure that we are actually finding things that are replicable and appropriate and true to some extent. So it's important that we standardize how we record, and the importance of moving on to the latest versions of how we record ethnicity is really important, because it allows us then to move on to more important questions in terms of, you know, cultural issues around religion, for example, but also in terms of sexuality and the whole LGBTQ plus agenda. So there are things that we just can't scratch any kind of or try and detail in any more detail, because we just don't have the data to be able to analyze that appropriately.
Hello?
Chris?
Any other views on that?
I guess just one thing quickly to add to Umesh is, I think because it's a dynamic population, so things are changing. So, for example, many more people of dual heritage. For example, I think we need to move to the 2021 census categories to be able to capture that and understand the intersectionality that Siraj has been talking about, and Jabir.
Thank you. And there's a specific question that's come in from Joel Parker. Tom, I hope it's okay if I can post this to you, is about ICSs. What opportunities do you think integrated care systems may offer to the particular health inequalities experienced by people with a learning disability from an ethnic minority background, given the more community, place specific and flexible approach to public health envisaged in these systems?
On a serious note, I really think there's a real opportunity for us here, for local ICSs to work with the NHS itself and beyond, and with partners to look at the needs of its population. We know that in each ICS there is an executive lead for people with learning disability and autism. It doesn't necessarily pick up on the ethnicity part of that, but it does begin to focus on that population. So I think there's a real opportunity here for local communities to be identified and worked with by local NHS and social care providers, particularly ones that have different populations. And one of the things I picked up from the report is, you know, there's lots of assumptions made about different ethnic populations. It's really important local NHS gets to know specifically their populations. I'm not quite sure if I've answered it fully, but I do see that opportunity is there. And there's a lot of flexibility with the Hughes review, particularly for ICSs to begin to focus on their priorities. Now, what we've got to do as a national team and using reports like this is to help them focus on particularly vulnerable groups as identified today.
Great, thanks, Tom. And just building on that, I know, Jabir, you've done a lot of work at the Race Equality Foundation around the concept of trust and confidence amongst local communities. We've got a specific question here from Peter Chang, which I'll pose to you, if that's okay. To what extent do you think a lack of trust in the healthcare system to meet the needs of ethnic minority communities may be contributing to underrepresentation in data samples?
Peter, trust is a key issue, and it continues to come up in the way the whole of the state works with minority ethnic communities. You'll have seen it in the media in the last couple of days again come up as a real issue. But yes, it does play a part in whether or not people choose to access support and access it at an appropriate time. If you feel that either you're not going to get the support you need, or that support is going to lead to your rights being compromised, you're unlikely to take it up until you reach crisis. And I think that's something that we really need to work on and address. But I think what we've also seen, and I think this report repeats it, is that where we have opportunities, particularly through voluntary and community organizations, if the healthcare system works effectively with those organizations, we can start building those bridges that will hopefully lead to an improvement in trust and care. It clearly needs to be accompanied by improvements in health and care itself, but there are ways of hopefully addressing some of the lack of trust that's there, and hopefully, as I said already, and what ICSs and ICBs are meant to be doing with their local communities should lead to a situation where we do engagement better and hopefully build trust.
Thank you, Jabir. Any other comments from the panelists on the issue of trust? I mean, we saw it so vividly, didn't we, through the pandemic, trust becoming a new determinant of health. Is there, are there any kind of quick solutions to kind of building and I guess rebuilding levels of trust and confidence in our healthcare system?
I was just going to add, Habib, I know there was a question around the findings around the Learning Disability Register, and that relates to trust as well. So this reluctance of being recognised and being on the Learning Disability Register was associated with self-advocates and carers worrying about what will happen if they are on the Learning Disability Register. So the fear of interference and the kind of fear of the unknown from health services. And a lot of people liked to be looked after within the family, and carers communicated that too. So I think that there's a trust issue and also a communication issue here around kind of what health services are going to do and what services can offer people.
Good point. And I think, Tom, you were going to come in as well.
I was just going to add, there's the whole issue, and there's a question there about having people with lived experience in core to planning health services, into working with the ICSs and working across the NHS and listening to those voices and being real about that. And whilst it may not just break down trust issues, it begins to show that organisations are really taking seriously the view of those who have experienced services.
I think there were specific workforce issues. I think one of those was around the acute learning disability liaison nurses and learning disability nurses being almost like unicorns as far as ethnic minority communities were concerned. There was a lack of, and we know that it's not a consistent kind of numbers across the country, but also culturally, there's a lack of nurses who potentially could support and help within those communities. I think the additional element is about normalising what happens. Part of that is creating quality improvement initiatives that take into account the fact that we should be looking at open access to data across the country, so we can compare and be able to look at how to improve. So without having that data, it's really difficult to try and improve things. And this has been a really important element of trying to get to grips with what we need to do across the NHS as part of this, but also social care really. And the two don't always match up when it comes to caring for people with learning disability and how they're recognised. And there's significant differences for ethnic minorities in that.
And just on that point, Umesh, we've got a question from Rupen Kelsey that says, or asks, we're facing a crisis on all levels, not just social and healthcare, but also in terms of rising levels of racism. Siraj is absolutely right about learning disability, ethnic minority people facing double discrimination. I feel we need solidarity across civil society organisations, local communities, not just those affected, so that we can push for change that we need. How can we build on this? Who would like to start by providing a response to that question?
It's Tom here. I'm not quite sure I can offer a response for society, but as Umesh was just speaking and about the workforce, there's something about how do we deal with the culture within health and social care, so that people who've got a disability, people who go from different ethnic minorities, are seen as the same as, I think people call it, the normal average white person. And how come we do enough to change the services that we've got so that they're accessible for all? I don't think it is an issue across society as well. But there's a bit of me that thinks, okay, we got to really focus on the NHS here, and we got to really focus with social care, the areas that we can control. But I find it hard to go beyond that, but understand that the point is really well made.
Yeah, absolutely, Tom. I totally agree. I mean, the NHS is not the only enabler for equity, but it has an important role in itself to play in society as well. Any other views on those issues around kind of allyship, but also, you know, making sure that the NHS is an inclusive organisation in terms of not just the workforce, but in terms of the services it provides?
I think, Habib, you mentioned the word equity, and equity isn't giving equal amounts. This is about being disproportionate, to the point of actually knowing that there is an inequity, and we need to do more than just leveling up. And that's an element that I'm not sure that we've got a clear grip on, of how do we try and improve care for the most vulnerable by being equitable. And at the moment, it just feels like we're trying to be equal rather than equitable.
There's a question here from Mary about, and she says, in my experience working with many ethnic communities, some communities did not want to be treated by someone from their own community due to suspicions that their information may get back to the community, even when reassured that this is confidential. Therefore, the generalization sometimes that this is what some groups want may not always be true. Have you come across this in your research? Umesh, come to you first.
I think Katie would be able to answer that. There certainly was a case. I think comments were made about this specifically, in terms of that there are cultural sensitivities in terms of how local communities may interact within, but there are certain communities we just didn't really get to really deal with in detail, because of the nature of the research being only for 12 months as such. So I know, for example, travellers and the Jewish community, we just did not have access to. And I know there are differences in terms of how certain cultures might expect to be treated, and how are expected to be treated by the NHS and social care. And we just need more detail, really. So it's hard to be broad about it, really.
Katie, do you have any views? And then I'll come on to each member of the panel for their final remarks as we close the webinar. Katie, do you have any comments on that particular point?
No, I don't have any further comments. Thank you.
Brilliant. Well, thank you all again. I'm just wondering whether each of the panelists want to say their final word, summing up from their perspective. I'll come on to Jabir first, and then Siraj, and then I'll go around, if that's okay. So Jabir, any final comments from yourself?
I think a key challenge from the working group was that many of them had heard about some of the evidence before. The worry they all had was how and whether things were going to change. And I think that's the challenge we really need to face now, is that we don't want to be coming back here in 2 or 3 years' time with similar evidence. What we do want to do is come back in 12 months and so show things have changed. We have started to take some of the steps that have been identified by this report.
Thank you, Jabir. Siraj, do you have any final comment?
Needless to say that we did the work together as a team, and let people know about this report. And we don't want this report to stay on the shelf and nothing happens. And we need to read this report, take it where we are, and have some actions and have this report as a life report. So wherever we are, whatever we are doing, we should be able to take this report in any setting and admit the difference in any setting.
Thank you so much, Suraj. Words of wisdom there from Suraj. Thank you so much. Umesh?
I think it's so great that we've had so many people join us today, and that's been a really important element of being able to not share our learnings, but hopefully there will be great examples of the positive practical things that we can do across the whole health and social care system. And I'm it'd be great to learn about those and find ways of being able to share those, because it is, as Suraj says, ways of learning. We've got to be able to do this together, and it will take more than just one thing. It's often little things. Many of those little things hopefully will change and make a big difference.
Thank you, Umesh. Christina?
Right, so I think that this report just really highlights that one-size-fits-all approaches to healthcare mean that some people get left out, and people from an ethnic minority with a learning disability will get left out from those sort of approaches. And what we need is personalised, person-centred care for people from these groups, and we really need to work on building trust in communities. And we have to remember with this project that, as Umesh said earlier, there were some communities that we couldn't reach at all, and they're not represented in the research, they're not represented in policy, they aren't represented in our working group or our workshops. And so we need to think about what's happening in those communities and how can we gain their trust and have them getting the healthcare that they deserve and they need.
Thank you, Christina. Chris?
I think for me, a couple of things. One is related to the question about racism. And I think something that Siraj, you and your colleagues at Changing Our Lives talk about a lot is that for allies, it's not enough to be not racist. You have to be proactively anti-racist. So I think that's one thing. I think another thing, I guess, is for those of us that are involved in research, I think there are some fundamental lessons for us in terms of who the research workforce is, what the questions are, how we decide what the questions are, and how we go about conducting research with the groups of people who we're talking about here today. I think that needs to be a fundamentally different research relationship and way of conducting research. So there's big lessons for researchers as well.
Thank you, Chris. And Katie?
Yes, I echo Christina and Chris's points really in relation to the research. As we've seen from the scoping review, more detailed research needs to be conducted, and as Christina says, this one-size-fits-all approach to healthcare really does not work. Thank you.
Thank you so much, Katie. And Tom?
So, thank you. What can I say in closing? I'm left with one. There's a sadness in the report, and when you read some of the stories, they're shocking. But the report provides an opportunity to double down, do more of what we're doing, but also expand in line with the recommendations, think much more about the ethnicity. So we've seen some of that in Leader, but there was a challenge there about, are we doing enough in the policy sphere? I'm also struck by the hearts and minds, and there's quite a few questions there about Oliver McGowan training. Does that cover it? Well, I think it will in a way, but not fully. So we need to do more about the hearts and minds. And I'm struck about what somebody with lived experience told me a few weeks back, and they just said to me, Tom, it's not rocket science. And what we have to do is break this down to the steps that make it people to understand what they need to do, whether you're a chief exec running an acute hospital. This is not rocket science. This is about creating an environment for people to receive the care in the setting that you provide. And quite often there are a number of relatively small steps that'll make that happen. It's not simple, but equally it's not rocket science.
Great. Thank you. Thank you so much, Tom, and the panelists. I'm afraid that's all we have time for It's been a truly insightful webinar, and the whole review process that has given us a real platform, to focus on action, and just taking on board the challenge that was rightly set by Siraj in his summing up. We need to build on the data and the insight to really focus on change. I think this report also provides us with concrete recommendations to improve care across the country, and working with NHS England and other organisations. That's exactly what the NHS Race and Health Observatory will be doing in the coming months. Can I thank the presenters and the panelists again, and can I thank you, the participants, for joining us today. Please keep tweeting using the hashtag RHO webinar. I see there are lots of tweets on the social media platform, and also the video link has also been shared in the chat Q&A function. It's also on the Race Equality Foundation website, YouTube channel as well. And the report can be found on the Race and Health Observatory website. Thank you again, and have a great rest of the day.